Chapter 21: Drugs for Neuromuscular Disorders and Muscle Spasms. Myasthenia gravis. This is an autoimmune condition that it impairs the transmission of messages at the neuromuscular junction and results in varying degrees of skeletal muscle weakness that increases with muscle use. It's also a chronic autoimmune neuromuscular disease that affects approximately 20 in 100,000 people. As we said, it is an autoimmune disorder where the antibodies attack acetylcholine receptors and obstruct the binding of acetylcholine while destroying receptor sites. But the lack of acetylcholine impairs the transmission of messages within that neuromuscular junction, leading to ineffective muscular control and weakness of respiratory and extremity muscles. This condition is characterized by skeletal muscle weakness, fatigue, diplopia, dysphagia, and again, that respiratory muscle weakness, paralysis, and eventually arrest. In the case of a myasthenic crisis, this can occur when muscular weakness becomes generalized and involves the diaphragm as well as the intercostal muscles. Triggers could be everything from emotional stress, pregnancy, infection, surgery, traumas, hypokalemia, alcohol intake, temperature extremes, medication interactions, or treat with neostigmine. In the case of a cholinergic crisis, this usually occurs within 30 to 60 minutes after taking excess anticholinergic medications. It's triggered by overdosing and severe muscle weakness, possible respiratory paralysis and arrest, abnormal pupil constriction, pallor, sweating, vertigo, excess salivation, and GI distress. Acetylcholinesterase inhibitors, also called cholinesterase inhibitors. These doses must be individualized, and it's a drug such as neostigmine that is short-acting, or pyridostigmine, which is an intermediate-acting. In both cases, these drugs work to promote the transmission of neuromuscular impulses across that myoneural junction. Side effects would include things like blurred vision, tearing, confusion, increased salivation, as well as fecal and urinary incontinence. Patients not responsive to these inhibitors may be given other drugs such as prednisone, plasma exchange, or intravenous immune globulins. In the case of pyridostigmine, we're going to look for clues and assess for evidence of any overdosing or underdosing, such as muscle weakness with difficulty breathing or swallowing. We're also going to be carefully assessing the respiratory system for gas exchange and oxygenation. We want to monitor the drug's effectiveness, as well as encourage the patient to wear medical identification, letting anyone know that they are on this medication. Moving on to multiple sclerosis. This is another autoimmune disorder where the body attacks the myelin sheath of the nerve fibers within the brain and spinal cord. It's characterized by remissions and exacerbations, weakness or paralysis of the extremities, fatigue, muscle spasticity, dysarthria, dysphagia, and diplopia, just to name a few. Multiple sclerosis is difficult to diagnose, and at least one other test should be used in addition to the medical history and neuroexamination. Everything from the medical history, neuroexam, in conjunction with MRIs, EEGs to measure electrical brain activity, and an analysis of the cerebrospinal fluid. There are many classifications of multiple sclerosis, everything from relapsing, remitting, primary progressive, secondary progressive, progressive relapsing, and a clinically isolated syndrome where the patient only has one flare-up of MS. This condition could be treated many different ways, everything from immunomodulators to immunosuppressants and monoclonal antibody therapy, as well as corticosteroids, working to reduce the edema and acute inflammation. In the case of skeletal muscle relaxants, these relieve muscle spasms and pain. The centrally acting muscle relaxants, while the mechanism is not fully known, they suppress the hyperactive reflexes. One common muscle relaxant is cyclobenzaprine. This relaxes skeletal muscles, relieving muscle spasms, and has side effects such as anticholinergic effects like blurred vision, dry mouth, tachycardia, urinary retention, and constipation. It could also include things like drowsiness, dizziness, headache, GI distress, and dysrhythmias. When giving cyclobenzaprine, we want to take careful assessment and note whether the patient has any history of narrow angle glaucoma. We also want to carefully monitor serum level enzymes, looking for CNS side effects. Teach the patient not to stop abruptly, but taper off over 1 week. Also teach the patient to avoid alcohol and other CNS depressants. For our first practice question, a patient with myasthenia gravis comes to the emergency department in respiratory distress. He's been diagnosed with myasthenic crisis. The nurse anticipates the administration of which drug? Would that be A, diazepam, B, baclofen, C, edrophonium, or D, neostigmine? That answer is going to be D, neostigmine. For our next question, the patient is admitted to the emergency department with cholinergic crisis. The nurse anticipates the administration of which of the following drugs? That be A, atropine, B, baclofen, C, edrophonium, or D, neostigmine. In this case, that answer is going to be A, atropine. Question 3. A patient with myasthenia gravis comes to the emergency department in respiratory distress. To determine if the patient is in myasthenic crisis or cholinergic crisis, the nurse anticipates the administration of which drug? That be A, diazepam, B, baclofen, C, edrophonium, or D, neostigmine. And that answer will be C, edrophonium. Question 4. A patient with myasthenia gravis is prescribed neostigmine. Which of the following indicates to the nurse that the medication is effective? That be A, increased muscle strength, B, decreases in sweating and salivation, C, changes in vital signs, or D, a decrease in generalized pain. And that answer will be A, increased muscle strength. Question 5. A patient with multiple sclerosis is being treated with large doses of corticosteroids. Which nursing diagnosis would be the priority at this time? Alteration in nutrition, less than body requirements, B, risk for infection, C, ineffective individual coping, or D, fatigue. And that answer is B, risk for infection. Anyway, that's all we got for this chapter. I'll see you in the next slides.